Start with a little, you could probably put up the slides for Liz. So Liz Spurgeon is another clinic-trained neurologist. It seems like I trained all of these people. There's a lot of nepotism going on here. If you want to get on the speaking program, come train with me. But again, I remember Liz just like I mentioned with Blake. She was single and doing her thing, and now she's married. She has a 10-month-old son who's already running around, and her life has gotten much more complicated. But again, just like all these guys, it's just so great to see people do so well in their careers and move forward, and it just makes everything seem worthwhile as we go through with it and all the great things that everybody's doing. So Liz is going to talk to us about epilepsy, which is always of great interest to everybody because we all look after epilepsy. And that's going to be followed by Susie. Susie's going to do some epilepsy stuff as well, and I'll give a little introduction when it's her turn. But Liz will start with some general stuff and then some cases, and we're delighted to have her. So thank you very much for your time.
All right. I'm a little bit smaller than Dr. Stevens, so I'm going to pull that down. Good afternoon. It's nice to see everyone. Nice to meet several of you outside in the hallway and in the mealtime. I'm Liz Spurgeon. I'm one of the epileptologists in the Epilepsy Center here at Cleveland Clinic. I completed my fellowship at Cleveland Clinic and went onwards to the next step. And I have had a pleasure working with Susie, one of our physician assistants who has been here a very long time and who's going to speak after me. So this talk on epilepsy and seizure management is quite long, thanks to Dr. Stevens. And so feel free to get up and move your legs once in a while. Okay, so let me get situated here. So we're going to divide this talk into inpatient discussion and outpatient clinic cases. So for the inpatient portion, I'm going to take you through one case of an inpatient consult with seizures as a primary concern. And in between the case, I'm going to highlight certain points that we should pause and reflect on. This case was graciously provided by one of our other epileptologists, Dr. Hantis. So this is a 76-year-old male. He was taken to the emergency department with left-sided weakness. He went to bed normally that evening, but did not attend an event the next day in the evening, and his daughter checked on him. And he was found to have left-sided weakness. So his NIH stroke scale, yes, I'm in the right department. I'm getting there. But his NIH stroke scale was 8. He had left hemiparesis and left hemianopia. He wasn't an IV tenecteplase candidate, but then, and this is his imaging, as you can see here on the CAT scan. He has hypodensity in the right MCA territory. This was his CAT scan following a stent placement and a thrombectomy, but unfortunately the extent of an injury was quite significant to the right MCA. This was his MRI. This is the DWI, bright area is the stroke. And here's the flare image. So obviously with an extensive stroke like that, he was admitted to our neurological ICU. He did require quite a bit of mannitol to get the swelling under control, did not need hemicraniectomy, but did require tracheostomy placement, PEG placement, needed a chronic Foley. He was sent to a LTAC. Where then, unfortunately, his course was even more complicated by infections, pneumonia, UTI, sepsis, C. diff even. So later on, several months later, now you see where I'm going, probably. Several months later, in December, he was acting more confused. So at his baseline, he actually did improve to the extent where he was able to speak a little bit, was interactive, and so this is how the family noticed a change in his neurological exam. So at that point, he was screened. He was found to have another UTI. He was on ertapenem, taken to the emergency room a couple days later when he was found unresponsive. And they also noted some twitching of his right shoulder. So this was his CAT scan in the emergency department. So he has evolving and more of an encephalomalacia of the right MCA territory. It did confirm that he still had a UTI. This was his MRI showing the extensive encephalomalacia of the right MCA. On his DWI, he did have a little bit of hyperintensity at this region of the right kind of parietal occipital region within that stroke, and this was the radiologist's read. It was thought to maybe be due to some Wallerian degeneration at that time. And so then, because he was found unresponsive, because his mentation was poor in the emergency department, he was placed on EEG. Now, I had to go through fellowship to learn how to read these things, so I don't expect, many of you may not look at EEGs routinely, so I'm just going to break down very, very basics of this. Even numbers represent the left side, left hemisphere, and, odd numbers represent the left hemisphere, and even numbers represent the right. In our institution, this is the montage that we use. We do temporal chains at the top. So this is left temporal and right temporal, so going kind of this way on the head. And then the bottom two are left and right parasagittal, so kind of going more following the midline of the brain. And so, as you can see here, it's very slow. There's not a whole lot of rhythm going on other than diffuse kind of brain waves that look pretty flat. Usually in a normal EEG, we see some varying frequencies of brain waves. So you can barely see much going on here, but pay attention to this region on the right. So his stroke was on the right, so we kind of have a bias. We want to pay attention to that region. Even at the very end of this slide, you can start to see maybe some little ditzel here, but I know what comes next. So let me click ahead. And so as we scroll forward, you see this kind of very distinct rhythm developing on the right, kind of central parietal occipital region here. So it's kind of C4, P4, P402. I'm going to click ahead. So this is the evolution of that seizure. It's coming from the right parietal occipital region, and you can see it on this section of the right, then spreads to the left occipital region. So this was his portable EEG. We already recorded one seizure, and so scrolling through, seizure activity is somewhat kind of continuing, waxing and waning. The end is a little bit hard to pick out on the seizure, but it's still going a bit here, and it kind of weans off. And then just to advance forward, this is his portable. Just to make a point, look again. Another one comes right after the end of that seizure. So already on the portable 25-minute EEG, he's had 2 seizures recorded, and this is a shorter seizure. It kind of tuckered out here, like a blip, 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 blip end. So two right parietal occipital seizures recorded on the portable, lasting a minute or 2 in duration, and he was unresponsive during that time. So no other clinical signs noted. So now we're assuming this patient is most likely experiencing a subclinical status epilepticus. So he was initially loaded with IV levetiracetam. Many people know this as Keppra. He was loaded with 4,500 milligrams. That's the maximum loading dose. 60 mg per kg is what we aim for, but it maxes out at 4,500 milligrams. And then they started 1,000 milligrams BID for maintenance. And then he was at a regional center, so they were initiating transfer to somewhere that has continuous EEG. So they did another portable while they were waiting for his transfer, and unfortunately more seizures were recorded, same area, right occipital, parietal occipital region. So they gave 2 milligrams of IV lorazepam, also people know as Ativan. They increased the maintenance dose of levetiracetam, and we're still waiting for transfer. Still, obviously paying attention to airway, breathing, circulation, all of those important components. Another portable EEG showed more seizures, so 2 more seizures. So at this point, he's already loaded with IV levetiracetam, so they move on to a second agent this time. They choose IV lacosamide, 200 milligrams to load, and then start a maintenance of 100 milligrams BID. The levetiracetam dose is not changed. It's still at 1,500 milligrams BID. And I will say, I should have put this on a slide, he does have normal kidney function. That's important to consider when working with levetiracetam. Levetiracetam doesn't injure the kidneys, but the kidney function being reduced can result in higher levels of levetiracetam. So that's something to keep in mind. And what do we like to check with lacosamide? So before we load someone with lacosamide, also known as Vimpat, we check an EKG and make sure their PR interval looks okay. Loading with lacosamide on a prolonged PR can potentially lead to heart block and arrhythmias and bradycardia, get into issues like that. So he had a normal EKG, he had a normal kidney function, liver function is normal. So his organ function looks good right now. So finally, he's transferred, eventually hooked to continuous EEG monitoring, and it shows very frequent seizures, status epilepticus. He's having 6 to 12 seizures per hour arising from the right occipital region. So here's his EEG, and we also utilize this function called the quantitative EEG, and that can help when looking at these long recordings. It can kind of highlight seizure activity, sometimes a little bit easier than scrolling through the file. We obviously scroll through every second of the file, but this is supportive data that we have. So here you see that same seizure activity. We're even numbers, so we're on the right here, and you see it spread through the right occipital region, and here's its evolution here. You can also see it here, which is another electrode on the right occipital region, and it kind of hops to the left side in the occipital region. So here is the quantitative EEG, and I'm not going to go into this on my PowerPoint, but I just wanted to show you, in case you haven't seen it, it can be a very useful tool that we have on continuous EEG monitoring, especially in status epilepticus where seizures are so frequent. So we use these different modalities to help us pluck these seizures out sometimes. And so each, as you can see here, something is going on here, something is going on here, and here, and here. So each one of these are seizures, and they measure different things. This is measuring rhythmicity of waveform on the EEG, so it's called the rhythmicity spectrogram. This is measuring frequencies. So the right hemisphere is red, the left hemisphere is blue, so we see a bit more red coming up on these areas where the seizures are occurring. And then down here, these also measure varying frequencies and amplitudes. So all of this, helps us record these seizures. But just to show as a fun piece of information, I'm not going to go into it any more than that. But so we have a case of status epilepticus, post-stroke status epilepticus and epilepsy. So far, what have we done to manage the status? So when he came in, we administered lorazepam, loaded with levetiracetam. Seizures continued. We repeated the lorazepam, loaded with lacosamide. Then he arrived here, and he had the opportunity to be enrolled in one of the trials that we were a part of at Cleveland Clinic, and it's called the RAISE trial. So I'm going to go into that later, but he did receive either placebo or the treating drug of the RAISE trial. But unfortunately, seizures continued. So he was then loaded with oral perampanel. And I'm going to also talk about perampanel later too, because it's kind of one of these new and up and coming seizure medications. So these two, just pause for a moment. We're going to touch on them in a little bit. But after the perampanel was loaded, so he was loaded with oral 12 milligrams, the seizures eventually stopped. So with all of these medications, and fortunately, we didn't have to escalate any further than that. Okay, so now I'm going to pause and talk more about status epilepticus and the management of it, including establishing treatment and then medications like anesthesia, and then more of the up-and-coming treatments that you can keep an eye out for as time goes on. So what is status epilepticus? So it's defined as continuous seizure activity or two or more sequential seizures without full recovery of consciousness between the seizures. And so the 30-minute definition is based on the duration that leads to permanent neuronal injury. So we don't, so even though the original definition of status epilepticus used the 30-minute guideline, that's not what we use to treat. So what we use to treat is the 5-minute duration, and that's to prevent this neuronal injury that can happen at that point. So the mortality is up to 30% in adults, so that's quite significant. And sorry, Dr. Hirsch and Dr. Boletko, but I'm also going to use time is brain in this setting. So rapid termination of seizure activity is essential in treating status epilepticus. So being prepared, knowing what to do, knowing the steps is just crucial. So I've gathered this information for you. It comes from the AES, American Epilepsy Society guidelines, as well as Neurology. So we're going to go through these. So this is from the American Epilepsy Society. This is an article from 2016. This figure was taken from that article, and it's a nice outline. It leaves a little bit in the unknown here, so let me just break that down. And later on in the presentation, I have a more updated article that's also helpful. But here, the first steps in status, as I mentioned earlier, is really establishing safety. So many of these patients are convulsing, or maybe they're completely unresponsive. So it's establishing, their airway. Do they need to be intubated? Oxygenation, their vitals, so heart rate, everything. Also, we very commonly check for blood glucose and basic things that can be reversible. If they're hypoglycemic, obviously we got to administer dextrose or sugar to have these seizures stop. So we check basic things, and then we go on to the treatment. So the first treatment of continued seizure activity, which usually we say, to administer after 3 minutes of seizure activity, these guidelines say after 5 minutes, is a benzodiazepine. And then following that, we go to our second line agents as listed here. So this table is here for your reference. I'm going to go into each step a little bit more thoroughly here. So the initial therapy, benzodiazepines. So there's different ways to administer a benzo in the case of status epilepticus. But so our data shows that IM midazolam, IV lorazepam, IV diazepam, and IV phenobarbital are efficacious at stopping seizures greater than 5 minutes. The most commonly used, I would say, is IV lorazepam and the IM midazolam, very easy to administer. So IM midazolam is as efficacious as IV lorazepam. So this is important also for EMS and people who are taking these patients to the emergency room. Sometimes they administer IM midazolam because it's very hard to get an IV established when someone's having convulsive seizures. So I am, and that's this point here, IM midazolam has superior effectiveness compared with IV lorazepam in patients without an IV access, and that's the reason for that. IV lorazepam is more effective than IV phenytoin, or some people know as Dilantin, in stopping seizures greater than 10 minutes. So once again, the benzodiazepines are our first-line agents, many studies to support that. So here's a question for you. So we're going to pause before I hop to the second line therapy. I'm going to ask you, which IV anti-seizure medication has been studied to be the most effective second line therapy at aborting status epilepticus? So A is fosphenytoin, 20 mg per kg. B, fosphenytoin, 20 mg, valproate, 20 mg per kg. C, well, I'm going to let you read it from here. But pay attention to the dosing and the medication. All right, and so how do we see? Oh, here we go. So we have the majority selecting C, but also some answers around the other selections here. So let's reflect on this question, and the majority has it right. So C. So fosphenytoin at 20 mg per kg, valproate at 40 mg per kg, and levetiracetam at 60. I always remembered this by 246, and just if you happen to remember the correct order of the anti-seizure medication. Let's see here. So this is the evidence of the ESET trial, which I'm going to go into, but basically it found that there are no difference in efficacy or safety outcomes in treating status epilepticus in these three medications. So A and B are incorrect just because they lack the other medications. D is incorrect because of the dosing problem. So valproate is ideal at 40 mg per kg and levetiracetam at 60. And then E is incorrect because that's our good first line go-to, not for a second line agent. Okay, so moving on from there. So let's talk more about the second line therapy. So this is the ESET trial called Established Status Epilepticus Treatment Trial. And this is what showed that there's no difference in efficacy or safety outcomes in these three medications. And here are the maximum doses listed here for your reference. And then we have the TRENDS trial, treatment of recurrent electrographic nonconvulsive seizures, which showed that IV lacosamide at 400 milligrams was non-inferior to IV fosphenytoin at 20 mg per kg. So now we have a fourth agent that's acceptable to use in the setting of status epilepticus. So what kind of things should we consider when choosing these agents, and what kind of things should we be cautious of proceeding forward? So here's a couple of clinical considerations when you're choosing these medications. So levetiracetam, also known as Keppra, obviously many people are aware of the agitation that can come with levetiracetam. It can be quite significant and quite limiting on using the medication, so it's something to look out for. And it also requires renal adjustments. No harm to the kidney, but the kidneys affect the dosing. Valproate, also known as Depakote. Obviously, with this medication, we want to watch for hepatotoxicity, the potential for pancreatitis, thrombocytopenia, encephalopathy at high doses, usually correlated with high ammonia levels in the blood. So in patients who come in status already with a liver injury or cirrhosis, or already with thrombocytopenia, you might want to pause and avoid using valproate if at all possible, and use one of the other agents. Fosphenytoin, things to consider is the risk for hypotension after a loading dose, arrhythmia, and a lot of interaction potential with other medications. So that's something to keep in mind. Lacosamide, as we mentioned earlier, we wanted to check that patient's EKG for that PR interval. So just to make sure that they don't have a heart block moving forward, it could potentially cause an arrhythmia. All right, so then third line agents. So after we administer these things, where do we go next? So sometimes we're in the situation where seizures are just not stopping, and we have to resort to anesthesia. So these are some of the options that we use for anesthesia and seizure management. The most common is midazolam, and this comes from the tremendous benefit we get from benzodiazepines in treating seizure activity. So, but what to consider with these medications, I mean, all of them, these top 3 can contribute to respiratory depression. So usually at this state, patients are intubated, needing ventilatory support. It can also result in hypotension. Propofol, what are the potential consequences of propofol? So also hypotension, similar to midazolam. It has a potential for pancreatitis, and it's high lipid solubility, so it can accumulate in these fatty tissues and lead to kind of a prolonged sedative state. It can take a while for someone to kind of get it out of their system, sometimes in some cases. Phenobarbital, so obviously respiratory depression and hypotension, like the above 2. Decreased cardiac output, ileus, that's mostly from being sedated, and immune suppression. So some things to keep in mind here. Ketamine is used sometimes for status epilepticus, and it has some features that are different from the first 3 medications. So ketamine can actually lead to hypertension. So that's something in certain clinical scenarios that might be more favorable than a hypotensive patient. Rarely leads to arrhythmias. Could contribute to pulmonary edema. Some patients experience kind of weird phenomenon on ketamine, like hallucinations, and I've heard of varying experiences on ketamine, so that's something to look out for. But it could increase ICP, and that's something to be really aware of in the neurological ICU. And a lot of our patients, we want to decrease the ICP because of swelling or whatever is going on. So this is why certain of these medications may be chosen over others. So this is the article I was referring to earlier. This was written in 2023, so it kind of gives a nice, I thought it was a nice figure that summarizes these recommendations. So here it splits it up into convulsive status epilepticus, non-convulsive status epilepticus, and then this is a topic I'm not going to expand on here, but Norris and Fires, so that stands for new onset refractory status epilepticus, so for unclear reasons, and Fires, febrile infection related epilepsy. So let me just highlight some things here and kind of summarize what we just spoke about. So for convulsive status epilepticus, it's even more aggressive than non-convulsive status epilepticus on stopping that seizure activity. So we have the first line agent, the benzodiazepine. Then we have the second line agent, and this gives kind of a general timeline here. Second line agent, which we've gone over, the third, and then it hops right to the third line agent. You're sedating. If convulsive status epilepticus is continuing at that point, you're going to have to sedate and intubate and get it to stop. And then as the seizure, if you hook to EEG, if the seizure activity is continuing in a non-convulsive manner, then you're going to be adding more of those second line agents and adjusting the anesthesia that you have. In non-convulsive status epilepticus, you may have a little bit more leeway here, where the main difference is you can kind of try to add more of the second line agents, but you're still going to want to stop this EEG seizure activity as quick as possible. So if time allows, you can load with one, you can load with another, kind of in our patient that we had, our case. And then if it's continuing, to really resort to intubation, sedation with anesthesia. Now this section here, which I'm not going to expand too much on, but sometimes we're in situations where a person is coming in with new onset refractory status epilepticus, seizure med, and seizures are still continuing without a clear reason. Maybe their CAT scan is normal, they don't have a stroke, they don't have a tumor, they're otherwise normal. So then we have to start thinking of etiologies pretty quickly and see, do we think an encephalitis is at play? Do we think there's an inflammatory condition? And in these situations, then we have to contemplate immunotherapy and getting more workup, such as a lumbar puncture and things like that. So always to keep etiology in mind. Our patient case that we had, fortunately, had a clear answer for us with a prior stroke. Okay, so summary of this case, we already went over this. So let me expand more now on what is this RAISE trial medication and perampanel. I know perampanel is kind of newly used for some people, so let me expand on those. But before I do, let me talk about the mechanism of status epilepticus, because then it kind of comes into play when talking about mechanism of action. So the consequence of prolonged seizure activity that we have found is internalization of GABA A receptors. The glutamate receptors, including NMDA and AMPA, increases at the synapse. And GABA receptors may also become insensitive to benzodiazepines. So this is, after acute phase where we're administering benzos, which are highly effective. If seizure activity continues, benzos can actually become less effective over time because of these mechanisms. Basically, GABA is hiding; the receptors are hiding and becoming more insensitive. But it's interesting to note that NMDA and AMPA increases at the synapse. And this comes into play when thinking of perampanel. So perampanel is an oral medication only, no IV, and it's a non-competitive AMPA receptor antagonist. So this may explain its potential benefits in administering during status epilepticus. So the data is somewhat limited in its use in status epilepticus, although it's suggesting benefit with reported response rates from what I could find of 33 to 58% in cohort studies. However, in these studies, they're administered in different ways and in different dosing. And by the way, perampanel is also known as Fycompa. You might know it by that name better. So the ideal dose for status epilepticus is yet to be determined. And I will highlight, let me see what's next. Okay, so I will highlight that perampanel given inpatient is very different from given outpatient. Perampanel is a very long-acting seizure medication. Its half-life is 105 hours. So it takes 2 to 3 weeks to reach a steady state of this medication. So in an outpatient setting, we have the opportunity to start low and go slow. So we start at a low dose and raise it up slowly. And this is partly to mainly prevent unwanted side effects from kicking in. And these unwanted side effects are usually mood changes, irritability, worsening depression, anxiety, if someone is to have a side effect. So in an outpatient setting, we may have that luxury of a bit of time to go slowly on the titration. And it's usually increased by 2s. So the starting dose is 2, and then you go up by 4, 6, 8, and so on. But in an inpatient setting, we're trying to act very quickly. And so in order to get that blood level up, we want to administer a loading dose of the oral perampanel. So this has been studied from a range of 4 milligrams to 32 milligrams. That's a big range. So we don't have clear guidelines on how to use perampanel in the setting of status epilepticus, but we have experiences, and we do have data to suggest efficacy, though. So in using these high doses, it was found to be safe, although that high dose of up to 32 milligrams is not clinically practiced. So I will speak for at Cleveland Clinic, based on, so there's 2 things. So based on our data, we do see benefits of perampanel with a loading dose. So after kind of our group meeting together and determining what dose we would like to use, we follow the package insert. And the package insert recommends a maximum dose of 12 milligrams. So that's our loading dose. So the way that we practice is we give a loading dose of 12 followed by a maintenance of 4. And then if seizure activity continues beyond, the next day, we give another loading dose of 12 and increase the maintenance to 6. And kind of so on, but we kind of lower the loading dose as time goes on. So that's one way to practice. And the goal of the loading dose is to boost up that blood level quicker than what you would see in an outpatient setting, where it takes 2 to 3 weeks to reach a steady state. So that that large oral dose is essential in kind of getting the benefits of perampanel. So more to come on that. I'm hoping, to see more trials on clarifying the use of it specifically during status epilepticus. So more to come there. And I will say the potential side effect of perampanel and loading at such a high dose could be sedation as well. And usually at that point, some people are on multiple seizure medications and they're having seizures still, so sedation is usually already kind of part of the picture. Okay, so then what is the RAISE trial, and what medication did potentially our patient receive in this trial? So the medication is ganaxolone. This is an IV synthetic neuroactive steroid, positive modulator of synaptic and extrasynaptic GABA A receptors, binding at a distinct site from benzodiazepines or barbiturates. So it's a steroid, and it also acts at GABA. So this has been studied in an open label phase 2 trial and phase 3, which I'll talk about next, but it was administered in patients over 12 who failed, specifically failed 1 or more second-line therapies. And so 0 out of 17 patients required treatment with IV anesthesia following its administration, and 16 out of 17 achieved and maintained status epilepticus cessation, so seizure cessation for 24 hours. And during the phase 2 trial, it was determined that it has a reasonable safety profile. It can result in, of course, increased sedation, but usually, at that point, people are already, there's a lot of confounding factors to that as well, multiple medications, seizures continuing, so that's one of its potential. So recently, there was a press release in June 2024, just a little bit ago, talking about the phase 3 trial component of the RAISE trial. So RAISE stands for randomized therapy in status epilepticus, and you capitalize the certain letters that correlate with RAISE. And so there were a couple of findings here. So the preliminary results show statistically significant proportion of patients had seizure cessation within 30 minutes of administration compared with placebo. So that's good. That's good news, promising evidence there. It did fail to achieve its other goal, which was statistical significance in patients not requiring IV anesthesia for 36 hours following its administration. But they're evaluating this more. They're looking at confounding factors. There's varying baseline traits of patients, like the severity of seizures, ventilation needed. So kind of more to come on that. So look out for evidence on ganaxolone. It may be something kind of up and coming in our future here. So serious adverse events were similar to placebo. So overall, it's on the right track, and we need more options sometimes. So this will be great coming out. Okay, and here are my references. So that was kind of my portion of the inpatient setting, which is focusing on status epilepticus. So I can kind of keep moving forward and go on to the outpatient setting. Does that sound